Good afternoon. Thank you for attending this Merck session of Meeting the Challenge. We have a topic on co-infected patient with Dr. Curtis Cooper, and Curtis, it was misspelled on the information sheet. We'll speak about tolerability drives adherence in English, presented by Dr. Bruno Speer from France, and case management by Dr. Sharik Haider. It's my pleasure to introduce Dr. Curtis Cooper. Dr. Cooper is currently Associate Professor at the University of Ottawa, infectious disease consultant at the Ottawa General Hospital, clinical researcher, and is involved in hepatitis C, HIV, vaccine, and mainly in immunocompromised population. So thank you, Chris.
We have had clinical trials to guide the management of our co-infected patients and treating them for hepatitis C for almost 10 years now. Before that time, it was difficult for any of our co-infected patients to receive therapy because there was this fear that they would get horribly sick with interferon exposure, and so we were told not to do it. These clinical trials came along and said that it can be safely done in well-selected patients, but the problem was that the results were pretty pathetic. 15% with PEG interferon ribavirin in the RIBAVIC study. Okay? A little bit better with the APRICOT study, 29% sustained virologic response for hepatitis C genotype 1 treated patients, but still not so hot. Okay? So then everybody said, well, we're using doses of ribavirin that are much too low in these studies. So they tried using bigger doses of ribavirin, and in this study they found that you could get around 39% sustained virologic response in our co-infected patients. Okay? So for the last 10 years, we've been using PEG interferon and ribavirin, and we're batting around 333 if you're a baseball player. 30 to 40% of our genotype 1 infected patients can hope for an SVR. Okay? This isn't really very good at all. We want to do better. Okay? When you look at the success of HIV therapy, you know, if you're able to deal with the adherence issues, and you know, we're talking 90% plus success rates. So, you know, we want to get to those kind of numbers. Okay? So, can we hope for more? Okay? And I'm happy to say that the answer is yes, we can. Just like HIV, hepatitis C has a protease enzyme. It has a polymerase enzyme. And these can be targets for new medications that are in development. Okay? That NS3 thing, non-structural 3, that is the target for multiple protease inhibitors that are currently either licensed or in development for hepatitis C. That NS5B at the end, that's the polymerase. There are nucleosides and there's polymerase inhibitors that target that. There's that NS5A. That's something that HIV doesn't have. It's responsible for assembly, and there's medications that are targeting that particular protein in the hepatitis C virus. So we have this arsenal of medications that eventually will be at our disposal for treating people with hepatitis C monoinfection, and hopefully we'll find the right ways to use these in our co-infected patients. Okay. So I'm happy to present on the data that's now just newly presented at CROI this year, looking at the two currently licensed hepatitis C protease inhibitors, boceprevir and telaprevir. Okay? I was fortunate enough to be involved from the inception and the design of this study all the way through the conduct and to the analysis and presentation with the boceprevir study here. So this is the rest of the group. Okay? So in this study, simple design, everybody received 48 weeks of pegylated interferon and ribavirin, okay, plus or minus boceprevir. Okay? You see the way you dose boceprevir is everybody receives PEG interferon and ribavirin by itself for 4 weeks, and then you add in the boceprevir after that. Okay? It was randomized in a 2-to-1 ratio, so 2/3 of our patients received triple therapy, and the other received the control group. This study, of course, was only in genotype 1 infected patients. Okay? These protease inhibitors that we are currently using are for genotype 1 only. Okay? That's not the same for other protease inhibitors and other hepatitis C medications in development, but for the ones that we have today, they're genotype 1 drugs. Okay? Keep in mind that the ribavirin dose ranged between 600 and 1,400 milligrams per day divided BID, and the actual dose is dependent on the patient's weight. Okay. Males and females were eligible, only genotype 1 patients. They were all naive to previous exposure to hepatitis C treatments. Okay. We needed to have a liver biopsy unless they were known to be cirrhotic. Okay. And of course, only well-compensated cirrhotic patients were allowed in this study. They needed high CD4 cell counts and fully suppressed HIV viral loads on antiretroviral therapy. Okay? Take note of the antiretrovirals that were not allowed in this study. No AZT, no DDI, no D4T. More important is the exclusion of NNRTIs like Efavirenz and nevirapine and etravirine. Okay. The population, this is pretty typical for most hepatitis C antiviral studies, whether they're co-infected or not. The mean age was in the neighborhood of 45 years old. 2/3 or so of our patients were male. About 80% were white. Very few were cirrhotic. So that's an important thing to take in consideration when you're interpreting the results of this study and the telaprevir study, is that not a lot of cirrhosis. Cirrhosis is a predictor for having lower success rates with hepatitis C antiviral therapy. Okay? As far as the genotype 1 breakdown, we had about 2/3 that were genotype 1A and 1/3 that were 1B. Okay? This is an important new thing in the treatment of hepatitis C going forward. With interferon and ribavirin, we didn't really care about the subtypes of the genotypes. It turns out that this is really important for predicting response to these new direct-acting antivirals, or these protease inhibitors, polymerase inhibitors, and nucleosides. Okay? So this is the money slide. You can see on the x-axis the weeks from week 4 all the way to the end of therapy at week 48, and then the sustained virologic response, which was defined as having no virus in your blood 12 weeks after completion of therapy. Now, I will remind everybody these are interim results. We'll see what the final results are, but this encompasses almost all of the patients except for 3 with the sustained virologic response rates. Okay? We started to get really excited about these results at about the week 8, week 12 time period. And as you can see, the sustained virologic response rates in the triple therapy recipients was 61%. Okay? And for genotype 1 population, this absolutely blows the doors off of anything that's previously been accomplished with hepatitis C antiviral therapy in co-infected patients. In our control group, about 27%, which is very similar to what we saw with the APRICOT study. Okay. As far as tolerability, it is well recognized that you have anemia with the use of ribavirin and interferon. It is also well recognized that you get additional anemia with the use of boceprevir in patients with monoinfection or with HIV hep C co-infection. So you can see that that was increased. A little bit more gastrointestinal side effects. There's this thing called dysgeusia. It's a foul taste in the mouth, and that's something that we've noticed a little bit more frequently in boceprevir recipients, and this has been well recognized in the hep C mono-infected patients. Okay? Aside from that, a pretty nice safety profile, very similar to what has been seen in hepatitis C mono-infected patients. Okay? So, in a nutshell, SVR rates of 61% compared to 27% with the previous standard of care. Okay? And the preliminary safety data demonstrated that the boceprevir can be safely used in our co-infected patients. Okay? Another equally important paper presented at CROI evaluated telaprevir. Okay? This study design was a little bit different. Okay? They targeted about 20 patients who were not on antiretroviral therapy to receive triple therapy with telaprevir, boceprevir, and ribavirin, or to receive placebo plus peg interferon and ribavirin. Okay? The way you dose telaprevir is a little bit different than boceprevir. You start all 3 drugs at day 1. You stay on all 3 of them until week 12. Then you stop the telaprevir and you continue your peg interferon and ribavirin. Okay? Everybody received treatment for 48 weeks. Okay? So in that Part A group, the patients were not on antiretroviral therapies. Okay? Then you see in the Part B, patients were either on an atazanavir-based regimen or an Efavirenz-based regimen, and they were randomized in a 2-to-1 fashion to either receive telaprevir, peg interferon, ribavirin, or to receive peg interferon, ribavirin. Okay. All I want to take from this slide is you can see that in those patients with not on antiretroviral therapy, their CD4 cell counts were over 600 cells. Okay. This population was very similar to the population that was assessed in the boceprevir study as well. Okay. Okay. This is the SVR12 rate. The overall results are in the gray bar there. And as you can see, 74% of patients receiving the triple therapy with telaprevir achieved a sustained virologic response, compared to 45% in the peg interferon ribavirin recipients. Okay? That's a pretty high number. We're still sort of trying to understand why it was so high in this population. Okay? The absolute difference between the two, well, you can do the math. It represents a major improvement in therapy as well. You can see that in the orange bar, not on being antiretroviral therapy, you saw a large improvement in SVR. If you are on Sestiva-based therapy, if you are on atazanavir-based therapy, all the results are very similar, an improvement with triple therapy. Okay? As far as the side effect profile, one of the key issues with telaprevir is rash. Okay? And in its worst case, the rash can be very severe. So if you're going to use this medication, you need to follow the patient frequently, and they need to understand that if you get any rash at all, you need to come and report that so that you can be monitored. Okay? In this study, in our HIV Hep C co-infected patients, didn't run into any issues with severe rash. Okay? You can see that there was a 34% occurrence of mild to moderate rash compared to 23% in the peg interferon ribavirin control arm. No additional concern with anemia and the use of telaprevir over peg interferon and ribavirin. Okay? So 74% versus 45%. Again, these two studies really represent a quantum leap forward as far as what we can achieve with treating hepatitis C in our co-infected populations. And telaprevir was found to be well tolerated in this group as well. Okay, so everything is all roses, right? We have great therapy. Well, sadly, no. We have a long experience in treating HIV that drug-drug issues are always a concern. Because both of these medications are metabolized through the liver, through the same enzymes that many of our HIV drugs are, there is the potential for running into problems that could potentially be clinically significant. This is one of my patients who mixed the wrong drugs together, and he became a squirrel. It's unbelievable. So I'm going to go through these slides and just sort of describe the potential interactions. This slide describes the effect that HIV protease inhibitors boosted with ritonavir have on your boceprevir and telaprevir levels. Okay? It's critical that you maintain your boceprevir and telaprevir levels, because if they get too low, you run the risk of not having enough Hep C protease inhibitor there to fully suppress the hepatitis C virus. That creates the environment where resistance can develop, and you can end up having a hepatitis C treatment failure if your levels are insufficiently high. Okay? This demonstrates that with atazanavir, darunavir, and lopinavir, the levels of your Hep C protease inhibitors decline, both for boceprevir and telaprevir. Okay? A little bit more of an issue with darunavir and lopinavir. Okay? This slide demonstrates the impact that boceprevir and telaprevir have on those same protease inhibitors. Okay? So once again, if you put somebody on a drug and it reduces the HIV drug levels too low, you run the risk of HIV virologic failure. Okay? If that drug-drug interaction results in having levels that are way too high, then you run into the issues with drug-related toxicities that the patient will have to suffer through. Okay? With boceprevir, you see that it dropped the levels of atazanavir, lopinavir, and darunavir. Okay? Pretty consistent effect across the board of somewhere in the neighborhood of a 50% decline in the C men. Okay? That's just one of the ways you can measure drug levels. Okay? With telaprevir, the levels of atazanavir, ritonavir went up. Not much effect on lopinavir, and a reduction in darunavir. Okay? This should suggest to everyone that this is going to be confusing. To try and keep all of this straight, you're going to have to rely on your own knowledge. You're going to need to rely on the expertise from your pharmacists. Okay? And there are some very good websites out there that can help you if you're really in a bind. You know, the Liverpool site is one that I'd recommend checking out. Okay. As far as the interactions with the Efavirenz, this demonstrates that with the use of telaprevir, it doesn't really have a major impact on your levels of telaprevir by combining it with Efavirenz. And with boceprevir, there's a bit of a decline in your boceprevir levels if you use that in conjunction with Efavirenz. Okay. This demonstrates that there's very little impact on the levels of Efavirenz if you combine it either with telaprevir or boceprevir. Okay. Finally, with the use of raltegravir, raltegravir isn't metabolized to the same enzymes that HIV protease inhibitors and HIV NNRTIs are. So, you know, at least theoretically, there was hope that this would be a drug that you could use, an HIV drug that you could use without worrying about the drug-drug interactions. This data with both boceprevir and with telaprevir suggests that is true, that you can use raltegravir without great fears of having a clinically significant impact on your hepatitis C protease inhibitors or on having an effect on your raltegravir levels. Okay? So that's all PK data. Okay? What we're really interested in is what is the actual clinical consequence of these interactions. For years, we have been using medications along with their HIV drugs that produce sizable increases and decreases, and we seem to be able to manage these quite successfully. Okay, so with the boceprevir data, there were 7 patients that developed virologic breakthroughs while they were participating in this study. 3 of them occurred in the boceprevir, peginterferon ribavirin group. 4 occurred in the control arm. So small numbers on both sides. There certainly was no signal here that patients were failing their therapies, their HIV therapies, or their hepatitis C therapies because of these drug-drug interactions. In the boceprevir study, most patients were either on Efavirenz, or atazanavir boosted with ritonavir, darunavir, or Kaletra. Okay? In the telaprevir study, there were no issues with HIV RNA breakthroughs. Okay? Remember, these patients were either on atazanavir, ritonavir, or Sestiva-based regimens. Okay? So at least with the telaprevir studies, we should be pretty secure in the combination of those drugs with telaprevir. Okay? So, as a concluding statement, I continue to believe that the majority of issues that our co-infected patients face and that we should consider when deciding whether they should receive hepatitis C treatment are exactly the same as our hepatitis C mono-infected patients. Okay? Our people living with HIV aren't made of glass. Okay? They're not going to fall apart if we put them on therapy. And there is a clear risk that if we don't do anything about their hepatitis C, they can potentially run into problems down the road. Okay? So I really think you need to take the same general approach for your workup, treatment, and long-term follow-up as a hepatitis C mono-infected patient. Okay? The one caveat to that comment is the drug-drug interactions will continue to be a significant concern, and we need to pay attention to this in the clinical setting, but I don't think it should mean that we should just say, no, we're not treating the hepatitis C treatment because these drug-drug interactions can't be overcome. I think we had the experience of 20 years of dealing with drug-drug interactions to know that it's actually quite the opposite. Okay? So thank you.
So we have time for questions. You can either go to the microphone or use the card on your table. So, Curtis, how easy it is to get these drugs? So for a patient in front of us with no protocol, can we wait the new drug or we have to use the classical old therapy? How can we select patients?
Okay, so this is the problem that we are all facing. Okay, our patients are facing this, and as healthcare providers, we're up against this barrier. We have been waiting for years to have improvement in our hepatitis C therapy for patients living with HIV. We finally have something that can provide, 60, 70% likelihood of success, and we can't get our hands on it. Okay? The Common Drug Review said no to these medications in HIV. None of the provinces cover it for patients with HIV. The ODB form goes as far as saying, does this patient have HIV? And if you tick off yes, then you're going to get a negative response every time. Okay? I have addressed the issues with efficacy. I think this data demonstrates that these drugs can be used safely in patients living with HIV. We're all aware of the drug-drug interactions, but they can be overcome. Okay? It just takes using our own clinical skills. So, the data's there. Okay? It will be published soon, and it's up to us to lobby the people that are responsible for approving and paying this. So if we want co-infected patients to have access to this medication, it's up to us to do it.
Thank you.